Good morning and Assalamualaikum to everyone. Thank you for joining us this morning. I hope all of you have a very nice mid-Friday morning session, although it's pretty raining this morning. Regardless, thank you for joining us today. Today, as usual, we've got two sessions. First session will be hosted by the Department of Pediatrics, and the second session will be hosted by the Department of Orthopedic. So I think without further ado, I would like to introduce our first speaker of the day, Dr. Nurshadia binti Samingan. So she is our lecturer as well as consultant pediatrician in our department, and she's also pediatric endocrinologist, one of my colleague in my team, in our team, pediatric endocrine unit in University Malaya Medical Center. So Dr. Shadia has been with us since 2008. She started with SLAB trainee, and she has completed her Masters of Pediatrics as well as Pediatric Endocrine here in the same center. And today she will be talking about childhood obesity. And of course, on top of that, she will be giving a little bit more insight as well as information on the new treatment and hopefully a new what we call it, hope for children with obesity and the use of liraglutide in this group of children. So, yep, Shadia, go ahead, and then hopefully we can have a little bit more time at the end to address some of the questions if any of you would like to ask us later on. Okay, go ahead, Shadia. Floor is yours.
Assalamualaikum and very good morning, everyone. Thank you for joining us. First of all, I would like to declare that I'm not the expert, but I will utilize this session for hopefully a beneficial and fruitful sharing of knowledge, and also the latest hope, I would say, for children with obesity. Okay, so what I will be talking about, first I would like to talk about obesity in children, and then what is the management of obesity and the use of GLP-1, and also some sharing session on our experience in using this new medication. So as we know, overweight and obesity worldwide has been a major concern and has been increasing exponentially for the past 30 years. And we are seeing more and more, not only adult, but also children who are overweight and obese. So the latest data from the National Health and Mobility Survey, they found that 1 in 3 children are in fact overweight or obese. So 1 in 3 meaning that 30% of our children are having weight problems. Yeah, so it means that if you see 3 children, you might find one of them are either overweight or obese. So from this 30%, 16% were overweight, and obese is 14%. Why does this happen? They also made a survey to look at the physical activities and also the dietary intake and the daily activities that they do. So we can see here that only 4 in 5 are in fact physically inactive. 2 in 3 being sedentary, meaning they just not doing much. They don't also eat enough fruits and vegetables, and maybe more towards fast food and processed food. 1 in 3 drinks carbonated soft drink every day, and 10% eats fast food at least 3 days in a week. So this with the opening of fast food till quite late night, and also mama restaurant, so this actually doesn't help with the progression of the overweight obesity in our community. This is a bit old data, so it's actually showing the how Malaysia stands in Asian countries. We actually number 2. So I think this data was in 2015 or 2016. But this time you can see the percentage is only about 13%, and we are already at the second place. So now it's 30%. So it has doubled more than it was before. So why does this happen again? So people's perception, children with who's looking chubby and looking a bit plump, they look cute and they kind of perceive as a healthy child because they are growing nicely. But in fact, it's not true. They think that overweight is average actually. Yeah, and we know that many children nowadays that we have a lot of access to online games and other types of games, Xbox, PS2. So children are indulging in more indoor activities. So about obesity in children, the BMI calculation is the same, weight over height times height, yeah. But children BMI numbers different according to age and gender. I would share the slide after to see so we can have a look at the chart. So there are also categories. Overweight is defined by more or equal to 85th centile. Class 1 obesity is more or equal to 95th centile. Extreme obesity is 120% of the 95th centile or 35 BMI of 35. And extreme obesity class 3 is 140% above the 95th centile or 40 BMI 40 for children who are pivotal. But for smaller kids or younger kids or under 2 years old, can use the weight for length or height chart, and obese toddlers or infants are considered if the weight for length is more or equal to 97 centile. So this is the WHO BMI chart for boys, as we can see. So 5 years old of a BMI 18 is already considered overweight, and about 16.5 is considered overweight. So this is obese for 18, yeah. But for 19, I think more or less the same as adult. And different for girls. Okay. I think you can get these charts online. You can Google it. Okay, so why is it recognizing and managing childhood obesity is important? Because we are seeing more and more adverse complications in these children, and why to prevent the complications becoming worse. Yeah, we have to think about preventing and halting the progression into adulthood. And if this continue into adulthood, then we are going to see a serious future health burden. Yeah, you will see more and more adult with diabetes, hypertension. Yeah, and this is the vicious cycle of childhood obesity. So a healthy child who's not having a good lifestyle, they can then become mildly obese child, and then when they start become obese, then they have problems with doing physical activities. Yeah, they feel tired easily, and I think for smaller kids, the ones that's young, they can be affected by Blount's disease. I'm sure the ortho doctors know. They might see some referrals of this because the bones are growing and they're so soft. So with the burden of the weight, it can cause the they might have the what we call as a genuvarum lah. Okay, and this continues into adulthood if they started and this not being halted or not, the progression is not stopped. So for children who are obese, usually 60% of the parents are obese, and from these children who are obese or overweight, 30% might progress into severe obesity, and about 50 to 60% can become the class 1 obese adult. So studies show that this obese or overweight children would become overweight obese adult if this no prevention or management not being taken. So what are the complications of obesity? I'm sure we know about metabolic syndrome, which consists of derangement in glucose, numbers, hypertension, derangement in the lipid, and they can also have hypercholesterolemia, fatty liver disease because of the buildup of because of the increase in carbs. Anyway, it can cause development of more fat tissue occupying the visceral organs. And we are seeing a lot of children with obstructive sleep apnea because of the obesity. And we also see some children might have very high blood pressure despite trying to find the pathological cause, but they are obese. So likely it is a essential hypertension, which we usually see in adult. And girls can be affected by polycystic ovarian syndrome, and many obese or overweight children face a psychological problem. They feel they might have low self-esteem, yeah, and this can also lead to depression. So the other part of management of obesity is we have to screen to make sure they don't have other pathological obesity cause, and look for complications as I have mentioned before. Okay, so the first line of management is always prevention and also lifestyle changes. So during infantile period, we should encourage exclusive breastfeeding, delay complementary food until 6 months old, and do not introduce sweet sugar or sweetened food to smaller kids, because if they are exposed to that and they prefer to have more sweet stuff, as it tastes, of course it tastes better. So if we introduce it at early age, so they might prefer that. Yeah. So for toddlers, you can encourage more physical activities, more time to play, and reduce the screen time. So, and for older children, we can encourage the use of technology, where now we can detect the they can have a pedometer or a watch that can that can show how much calorie they burn and so on. Yeah. So moving on, apart from prevention and also lifestyle modification, we also have pharmacotherapy to manage obesity. So from as early as 20 plus years ago, Orlistat was introduced, and this was for age 12 and years and above. It is to decrease the lipid absorption, but it has a lot of side effects where patients can have a lot of flatulence and also unpleasant diarrhea because of the oily stools. Yeah. And the next is in 2013, the FDA approved the use of phentermine. It is an agent to reduce the norepinephrine uptake and stimulate neurons in the hypothalamus and serotonin and dopamine uptake. So it can inhibit the appetite. Okay, liraglutide. Liraglutide is the agent that we would be discussing today. So it's approved to be used in age of more than 12 years, and it's a daily, but anyway, it's a daily subcutaneous injection like the insulin. This is a glucagon-like peptide receptor agonist. How does it work? It enhances insulin secretion, slows the gastric emptying, and there's a direct effect in the CNS. And there's the other agent setmelanotide, but this is only to be used in some genetic cause of obesity. It's also subcutaneous, and I think this is only used in the United States or maybe in some European countries. And recently, about 2-3 years ago, phentermine plus topiramate is also used. And again, this is approved in US and some European countries. And another type of GLP-1, which is a semaglutide, the one that you can have the weekly type and also oral type. but the use is not approved for Malaysian children yet. Yeah. Okay, so how does GLP-1 act? It is mimicking the endogenous. Actually, the body has GLP-1, which is secreted by the gut cells. So how does it act? It acts on the receptors, and this will cause the CNS effect where it reduces satiety, increase satiety, and reduces appetite. So that would lead to reduction of the fluid intake. It improves insulin sensitivity where it encourage more insulin secretion, and it inhibits glucagon secretion. So in a way, it helps in glucose excretions. And it also delays the gastric emptying so that the satiety feeling is longer, and also reduces the gut motility. So we know that liraglutide has been long used in adults. So this is study which was published 10 years ago in 2015, and they have a lot of many patients that was recruited. So a total number of 3,000 plus. So 2,000 plus were recruited in liraglutide, and the other 1,000 plus in placebo. As you can see in the graph A, the group with liraglutide, they have better in terms of normoglycemia and prediabetes. We can see the change in body weight is more in the liraglutide, and as well as the percentage of the weight loss, more patients had more weight reduction compared to the placebo. And in terms of metabolic parameters, in terms of H1C, glucose numbers, high blood pressure, and also the cholesterol lipid profile also showed a significant difference in terms of use of liraglutide versus the placebo. So what about the adverse events or side effects of GLP-1? So the most common one, if you can see at this table, in 2,481 patients, actually 80% of them, which close to 2,000, experience adverse events. So most of the adverse events is nausea, diarrhea, some complain of diarrhea, some complain of constipation, and some also had vomiting, abdominal pain, and the list of the side effects, including back pain, arthralgia, headache, serious adverse events, less than 1%, actually about 0.2%, affecting 0.2%, including cholelithiasis, osteoarthritis, pancreatitis. So very small numbers had serious adverse events. So this medication is deemed safe to be used for people with obesity. So what about the use of liraglutide in children? So recently, this is an article that was just recently published last year. So our center was one of the centers that was given the chance to be included in the study, led by our Professor Muhammad Yazid. So this is looking at the use of liraglutide for children 6 to less than 12 years old with obesity. So, okay, this is a poster, a visual poster to summarize the study. So, they had all these children, the numbers are 82 children, I think from 9 centers worldwide, aged from 6 to less than 12. So the mean age of the children who were recruited 10 years old, boys and girls more or less the same, 50 to 40%. So they were first recruited and initially was planned for dietary and also lifestyle interventions. Okay, after 12 weeks, they were evaluated and they were given this placebo or liraglutide, and it's a double-blind randomized study. So what they found is those with placebo would see some actually indeed increase in the change in the BMI, and as we can see, those with the liraglutide group, they have found a significant difference in terms of the BMI change. Yeah, and uh, of course, in the adverse events, we would see more in the liraglutide group because this is already shown in the adult studies as well. Okay, so I would like to share our experience in the use of liraglutide for our patients. So we have a total number of 6 patients, and with the youngest age of 12 and a half, and the eldest would be the 17.8, close to 18 years old. So with the duration of liraglutide of from 2 months up to 9 months, it shows some variability in terms of the weight change and BMI change. But we have our biggest loser, which is patient number 4, which who used liraglutide for 2 months with actually the not the maximum dose. The maximum dose is 3 milligram. We start with 0.3 milligram, the initial dose, and we titrate according to the patient's tolerability, because the higher the dose, the riskier to get GI side effects. So we do the titration over 1 or 2 weeks and see how they can tolerate the side effect. If they can tolerate, we can increase to the maximum dose. So this patient who is 15 and a half, just use the liraglutide for 2 months with a dose of 1.8. So start with 0.3 and then 0.6 and then 1.2 and 1.8. So it's like in the almost slightly more than half of the maximum dose. And you can see that the BMI also has reduced much from 35 to 31.5. And he also lost 9 kilo with BMI change of about 3.5. Yeah. And in the first and 2 patients did not differ much in terms of the weight change. I mean, the other thing that we have to question whether they are complying with treatment, because all these patients are being monitored outpatient. Patient 1 had BMI change, I assume, because patient was still growing. So the weight, although it didn't differ much, so it actually prevent further weight gain for this patient. And BMI eventually had some difference because the patient is still growing, as opposed to this patient is 17 years, almost 18. So this patient might not be growing anymore, might have attained final height. So that's why the BMI is no change and just a very, very small change in the weight. And the rest, we have quite a, I would say a satisfactory change in terms of the weight. Yeah. So it's frozen up. Sorry. Oh, yeah. Okay, so with such a small numbers, I just put as average lah, because it's not really normally distributed. So I would just average the weight loss of our patients. So about 4.2 kilo, which is quite good in the span of from as shortest of 2 to 9 months, and average BMI reduction is about 2.4. And the average dose is 2.5. So 2.4, because the pen is the increment is by 0.6. So maybe about 2.4. 2.4 is not yet the max lah. And average duration of 5 months. So in terms of side effects, most of them do not experience side effects. As you can see, patient number 2, number 3, and number 5 had some side effects, but it's not too bad that would cause them to stop the medication. But anyway, what we advise, if they have some side effect that they might think that not really tolerable, they can just stop at the or continue at that current dose that doesn't give them much side effects, and see if the side effects no longer experienced, they can slowly again titrate it up to see if they can tolerate the higher dose. Okay, I've come to the end of my talk. So I would like to conclude that childhood obesity is common, 1 in 3. And I think we will see more and more because of the lifestyle, the way that we leading our lifestyle now. And lifestyle change is still the first line of management. And pharmacotherapy now can be offered. Don't wait and watch. If let's say the patient has they don't have any change, and in fact they keep on having their weight and BMI increase, you might want to consider pharmacotherapy. And long-term effect of GLP-1 still need to be studied. As we can see, the study before, it was in 56 weeks, right? So that is just 1 year. So these patients who were, the data that was published, I think the study will have another follow-up study at 1 year after the stop of the liraglutide to see whether they can sustain the weight loss or can keep the same weight, no weight gain. But previous studies, I think adult has seen that most of these patients might have a rebound in terms of weight. So considering the cost and then the duration, these are the other factors that you have to think about. How can we do better? Okay, and again, I would like to stress that prevention is better than cure, because cure is very costly, and of course the complications can be serious that might also again progress into adulthood. Okay, thank you very much for all your attention. So again, the problem is obesity runs in the family, they think, but the real problem is no one runs in the family. Okay, thank you so much.
Thanks, Shadia. We've got very short time to try and address some of the questions. Thank you for the first question that has been given in the Q&A box. Shadia, what happened to the patient after stopping liraglutide, and did they sustain weight loss or lifestyle changes?
Well, the patients, we don't have that many patients. So from I think the small numbers of patients that I've seen, I think both of them has regained their weight. So yeah, it's
okay. From our perspective, both myself and Professor Yazid, we have a little bit more a group patient. I think what Shadia has shown earlier on is particularly in UMMC. So you clearly understand that it is very costly. And this group of children are usually selected if they have their parents' GL. Maksudnya, if let's say their parents have a JPA coverage or hospital coverage, then or a staff coverage, then usually we'll try to enroll them first into the program. I have to say, like what Shadia said, that we don't have enough patient that has completed. I've got 2 patients that has completed the liraglutide treatment. So what I can say, number one, is that we need to make sure that they have made the necessary lifestyle changes first. So during that 1 year of treatment, they need to understand that they cannot eat a lot, because this treatment can actually show that they need to start understanding that small eating patterns, small food portions is necessary to sustain that weight loss, change of lifestyle behavior. And we hope that 1 year duration is enough to help them to understand that perception. And although studies have shown it's only up to 52 weeks, if we do see that patients are getting better or doing very well, we can actually continue to continue with the treatment as long as the weight gain is steady and safe, and until to the level where we think it's healthy and necessary and stabilized, so that they don't have any excessive weight gain again, a rebound. And what I tend to do as well is that to cut them down to maintenance level and then slowly cut it down rather than abruptly cut down or stop the medication immediately. So I hope that also give some sort of like insight towards this. Do you have any more burning questions? Maybe last one question, if anybody, before we can submit, or before we can transfer the session to the Department of Orthopedic after this. Excellent. So if you don't have any more questions, you can continue to ask in the Q&A box. We can try to assist, and we can try to answer your question, within that chat box, a Q&A box. So without further ado, I pass the floor to Prof. Faisal. So you can take over and have a good session on the orthopedic topic this morning. Thank you, everyone. Thanks, Shadia.